here would be, so I thought the idea here would be to cover some basics. Much of this may be very familiar to those of you who already know that you're carriers and have been through the high-risk clinic. But in our town hall meetings to discuss what material should be included, people did ask for some information about some basics, and I think it'd be worthwhile having it in our library for anybody who might be looking at this recording in the future. So the outline of this talk is we're going to talk about genetic basics. Then I'm going to talk about the cancer risks associated with BRCA mutations, how one goes about getting tested, and then I'm going to talk about risk management for all of the cancers that we know to be associated with BRCA mutations. And at the end, I'm going to talk a little bit about lifestyle issues and what impact they might have on cancer risk. So the genetics basics, or genetics 101, we can call it, is to talk about what a gene is and what genes do, what are BRCA genes and what do they do, what is a mutation and how do mutations increase cancer risk, and then how are mutations inherited. So cells in our bodies have nuclei, which contain chromosomes. My next slide will have some pictures to summarize this. And chromosomes are made up of DNA, which instructs our body how to work. And these instructions are in the form of genes, which guide our cells to make proteins. In our cells, we have 23 pairs of chromosomes, and we get one of each pair from each parent. So here's your picture of a cell with a nucleus with chromosomes. And the chromosomes are made up of DNA, and a section of DNA being a gene. BRCA1 and BRCA2 are what are called tumor suppressor genes. They instruct our cells to make proteins that are involved in the repair of DNA. Our DNA gets damaged in our lives, both naturally or from outside sources like radiation or chemicals. And the failure to repair damaged DNA can lead to cancers developing. A mutation is like a spelling mistake in a gene that can result in a protein not being made normally. If you have two normal BRCA genes, even if one gets damaged, you have a backup system. But when you have a BRCA mutation, one of your genes doesn't work properly. So if the other is subsequently damaged, you'll lose the ability to make proteins and repair DNA. It's important to know, though, that mutations in BRCA are not common in the general population, as we think only about 1 in 400 people have a BRCA mutation. So this is just a pictorial representation of a normal gene making a normal protein and a mutated gene making either an abnormal protein or not making a protein at all. So how do we inherit these mutations? When a sperm or egg is formed, it contains one of each pair of chromosomes that is found in a normal cell, so half of the normal chromosomes. And when an egg is fertilized, the chromosomes from the egg match up with the chromosomes from the sperm to make a full set. So the abnormal gene can come from either the sperm or the egg. You can inherit the mutation from either parent. And similarly, if you have a mutation, there's a 50% chance that you can pass it on to your child, whether a boy or a girl. So this is just showing here a man who has a BRCA mutation. His partner does not have a BRCA mutation. If they had 4 children, statistically, 2 of the children would have acquired the BRCA mutation and 2 would not. Again, either boys or girls could get the mutation. In general, hereditary cancer is not common. So when we look at all cancers, only about 5 to 10% of them are actually known to be due to gene mutations. About another 10 to 20% have increased risk in a family, but we think that those are due to multiple factors, perhaps many different genes acting together or environmental factors. But all of the rest are really sporadic. So that means they're happening due to other causes, not related to genetic problems. So as a physician, what's a red flag for me that somebody might be at risk of having a BRCA mutation? And similarly, as a patient, what might make me think that maybe I have one? So a woman who has a breast cancer at age 35 or younger is more likely to have this related to a mutation. If they have a breast cancer that is not hormone sensitive, if they have an ovarian or fallopian tube cancer, if they have both breast and ovarian cancer in their lives, if in the family there are multiple people on the same side of the family with related cancers like breast and ovarian, if a man has breast cancer, if a man develops metastatic prostate cancer, or if someone has pancreatic cancer. Still, only about 10% of these people will actually have a mutation, but this is how we identify people that we think are at increased risk. And it's important also to recognize, as many of you already know, that the BRCA mutation is higher in certain ethnic groups, particularly in the Ashkenazi Jewish population, where the risk is 1 in 40. So we have kind of an extra red flag going if you have some of these features and you're also Ashkenazi. So what are the cancer risks associated with a BRCA mutation? So this chart is of the lifetime cancer risks up to age 80. In the right side of the screen is the risks in the normal population, so people who do not have a mutation. And then the first and second columns are the risks associated with BRCA1 and with BRCA2. You can see the most common cancer is female breast cancer, and the next is ovarian cancer in BRCA1, and probably prostate cancer in BRCA2. Pancreatic cancer is increased, but not that common. Male breast cancer is not common, but it's way more common in mutation carriers than it is in men who do not have a mutation. Now, these risks, these are averages. An individual's risk is modified by a lot of different factors, including their family history, their lifestyle, but we only have data looking at large populations right now, and that's really the only numbers that we can give people currently, though things are changing in that regard. So there's a number of different ways that you can get tested to see if you have a BRCA mutation. The most common is by going through the Hereditary Cancer Program at BC Cancer, where you can either refer yourself or your physician can refer you. You fill in a questionnaire that determines whether you meet the current criteria for testing. And if you do, then you will be sent a lab requisition to have blood work done. And when the results come in, you will be contacted and arranged a meeting with a genetic counselor if you turn out to be a mutation carrier. Some people also choose to go through private pay testing. So there's a number of labs in the US primarily where you can pay to have genetic testing done. Programs like Ancestry and 23andMe are not recommended for testing. They have a problem with their accuracy rate. So if somebody does go through that route and has a positive test, we have to repeat it. And if they have a negative test, there's a chance that it's not true. And the final way, which is not the preferred way, is that when a patient has a cancer diagnosed, if they have those red flag features, then the blood test can be ordered by their cancer specialist. The reason that I say this is not the way we like to see it is because we'd like to be preventing these cancers rather than finding out people are mutation carriers after the fact. So what happens if you are found to carry a BRCA mutation in BC? So you see the genetic counselor and you're given a discussion about the risks, just like I said in the previous slides. And the recommendations for your risk management are given to you, and a note is sent also to your primary care provider. If you're a woman, you can be referred to be seen at the Hereditary High Risk Clinic, where we see both women who have tested positive and also see women who have not yet been tested but have a 50% chance of carrying the mutation. Some people aren't ready to know yet. Patients can also be referred directly to the high-risk clinic by their cancer specialist once they've finished their treatment and follow-up for a cancer. And we see patients throughout the province, either by telephone if you do not live in the Lower Mainland, or in person. And we do consultations where we discuss your risk and get a risk management plan for you going and set up, and then arrange an annual follow-up. So at that first meeting, all of the risks associated with your mutation would be reviewed. Your health would be reviewed because the risks may be modified by other factors. We arrange screening, surgical referrals, and follow-up. One of the things that has come up in questions when I'm seeing women is whether pregnancy and nursing influences breast cancer risk, because in the general population, we know that pregnancy is protective and nursing is protective. In BRCA mutation carriers, there's some inconsistency in the research, and that's pretty much why I don't talk about it at the high-risk clinic. But what the data does show is that, sorry, I just got to move something here, is that if you're a BRCA1 carrier and you're pregnant more than once, it does reduce the risk of developing breast cancer. And the more pregnancies you have, the greater the risk reduction, up to about 50% risk reduction. Interestingly, getting pregnant later is actually beneficial, which is a little bit different than in the general population. And there's a suggestion that only having one pregnancy might actually increase your risk. Breastfeeding does reduce the risk, and the longer you breastfeed, the better. There's about a 32% reduction in breast cancer risk if you breastfeed for 1 year. There's a little bit of a balancing act that has to go into play with breastfeeding, because we can't do screening with breast imaging while women are breastfeeding. So it gives the opportunity then of missing a cancer if it does develop. The research is quite different for BRCA2. It appears that pregnancy might actually increase the risk, but it's the other way around, except if you have more than one child under the age of 40, which seems to reduce risk. I think most people are not going to be having children based on how it influences risk, but it's something that people do ask me about, and this is our current understanding, and where we go from it. It does have some interesting implications. For example, in Israel, which has a large Ashkenazi Jewish population and a large Orthodox religious population that have a large number of children early, their cancer rates are lower than the numbers that I've shown you here. And it's felt to be related to that kind of different hormonal background because of their proclivity to get pregnant and have children. So there's several different approaches to risk management for a woman that has a BRCA mutation. One is to have increased screening, and we recommend that women have an annual mammogram starting at age 30, and we continue that at least till age 75, older depending on what the woman's health is. And I just want to mention here, because there's some confusion, is that screening mammograms, the screening mammography program, is a perfectly appropriate place for mutation carriers to have their mammograms. The only exception is if you have breast implants or you've had a previous breast cancer. In those two situations, you have to have your imaging ordered by a physician, not through the screening program. But a basic screening mammogram is exactly the same as a basic diagnostic mammogram. You're not getting a different test depending on how it's ordered. It's just the process by which the imaging is done. In addition to the mammogram, we also add an annual breast MRI starting at age 25, and we currently continue those until age 70. MRI is much more sensitive to detect cancer compared to mammogram, but it also identifies more abnormalities that don't turn out to be anything compared to mammography. So the two balance each other when you get better results when you do both than just doing one. The imaging isn't perfect, so we also recommend an annual physical examination of your breasts, and that women be aware of their breasts, which means pay attention whether you're doing a self-examination or checking yourself in the shower, and that you see a physician if you noticed a breast lump. There are studies done looking at whether screening is worthwhile, and yes, having screening is better than not having screening. There is a higher survival rate for cancers detected with screening than those detected in patients who are not involved in a screening program. This is just for your interest. This is what breast cancers look like on mammograms. So a couple of different pictures there. And then on the right, that's what calcifications look like. And calcifications show best on mammogram and don't really show very well on MRI at all. And this is a picture of a breast cancer on MRI. The cancer isn't actually red. That's a computer overlay that's based on blood flow that the cancers look red. So women also have the option of having preventative surgery to reduce their cancer risk. And that can be done with or without reconstruction. People do not have to have a reconstruction if they don't want to. It is a procedure. The reconstruction is covered by medical services if you do want to have one. And that surgery reduces the risk of developing breast cancer by more than 90%. It's not 100% because it's technically impossible to remove every cell. After that surgery, you don't need to have mammograms or MRIs for screening. We still recommend an annual physical examination, either of the reconstructed breasts or of the flat chest. And if any lumps develop, then those need to be investigated. And again, like for your own breasts, if you have a reconstruction or a flat chest, you need to pay attention and see a physician if any new lumps develop. The primary benefit for risk-reducing surgery is reducing the risk of getting cancer. The general message is it's not thought to improve overall survival. So you're not more likely to be alive when you're 90 if you have your breasts removed than if you don't, because the cure rates for screen-detected breast cancer in a high-risk screening program are high. Mathematical models say there should be a small survival advantage of about under 5% for a woman who had preventative mastectomies at the age of 25. Recently, there's been a bit of research showing that that might be the case, but it's still not definite. And in any case, the benefit is small. It's 5% compared to the 90% benefit in just reducing the risk of developing breast cancer, having to go through treatment, chemotherapy, and the stress and worry in the future after that would entail. Generally, though, preventative surgery is a personal choice. There are very few circumstances where I would say to somebody, you should have a mastectomy. There's a third option that most people are not familiar with until they come through the high-risk clinic, and that's what we call chemoprevention or medication for risk reduction. So there are a number of drugs available that if you take one pill a day for 5 years, they reduce the risk of developing a hormone-sensitive breast cancer by 50%. These drugs all have different side effects. Unfortunately, very few people choose to do this. I don't really know why that is. I like to point out that almost everybody over the age of 50 is on a statin to reduce their cholesterol level and doesn't seem to have any questions about doing that, even though it's not nearly as beneficial as tamoxifen for breast cancer risk reduction. But it is an option, and something that I am hoping we can figure out how to get more people interested in trying in the future. One of the other issues that comes up for mutation carriers is, what do you need to do if you get a breast cancer? So in my experience, about 95% of the patients in the high-risk clinic who develop breast cancer choose to have bilateral mastectomies. It's actually not mandatory. It's not associated with a greater chance of survival. Basically, you've already had your cancer. There is a higher risk of a future cancer on the other side in mutation carriers. So that's one of the reasons that so many women choose to have preventative surgery on the other breast. Also, it's important, though, to note that medications like tamoxifen, which are used for treatment of breast cancer, or removal of ovaries, which is also used as part of breast cancer treatment, does reduce the risk of developing the cancer on the other side too. So I think there needs to be a bit of thoughtful decision-making and not necessarily a reflex. I have to have both my breasts removed because I developed a cancer. At least at this time, we don't have any evidence that that's mandatory. What about for men? So if there's men in the room, I'm not looking at the whole screen here, but the reason that we don't see men in the high-risk clinic is because we don't order any imaging routinely. We don't do MRIs in men. We recommend a clinical breast examination beginning at age 35 and breast awareness. And there's some now suggestion in the guidelines that maybe a man should have a baseline mammogram at age 40. Maybe they should have annual mammograms at age 50. It's not really definite. I mean, the risk, if we look at a BRCA2 carrier, we said the risk was 5 to 10%. A woman who does not have a mutation has a risk of 12%. So there's sort of a bit of a comparable risk there, which is why there's a discussion about whether mammography should be done in men who are mutation carriers. But it's not a strict must be done currently. Ovarian cancer is a little bit more complicated. We don't have any effective screening for ovarian cancer. Studies have been done looking at blood work with CA-125 and at pelvic ultrasound, and they haven't been able to detect ovarian cancer early. It's a cancer that grows quite silently, and by the time women have symptoms, the cancer is usually quite advanced. And then, unlike breast cancer, the cure rates aren't very good, even with chemotherapy. So because of that, it changes our approach to risk management. We do know that taking the birth control pill for more than 5 years reduces the risk of ovarian cancer by 50%. Now, for the BRCA2, the lifetime risk was 17%, and for the BRCA1, it was 44%. So even a 50% risk reduction still leaves you with a pretty high risk of a lethal cancer. Consequently, the current recommendations is that women have their fallopian tubes and ovaries removed preventatively. And the age recommendations are 35 to 40 for BRCA1 and 40 to 45 for BRCA2. The ages are different because it reflects when we usually see the breast cancers in carriers with those different mutations. Preventative removal of tubes and ovaries reduces the risk of developing an ovarian cancer by at least 90%. And It also reduces the overall risk of death by 70%. So it's called improving your overall survival. If you're a mutation carrier and you have your tubes and ovaries out, you are more likely to be alive when you're 90 than if you don't. It does also reduce the risk of breast cancer, definitely for BRCA2, a little bit controversial for BRCA1 regarding the numbers. So some studies say yes and some studies say no. And part of that is because BRCA1 carriers are more often have hormone not sensitive breast cancers. So those we wouldn't expect those to be less common if you had your ovaries out. We do recommend hormone replacement till the age of 50, and this is really important. It's actually not good for your whole body to have your ovaries out premenopausally. It can cause bone thinning. It increases your risk of heart disease. Might be associated with a higher risk of memory loss. That is the intention of the hormone replacement, and we recommend the treatment for at least 5 years. Longer, we're not sure about. Generally, we currently recommend it be continued to age 50, which is pretty close to the natural age of menopause. In the future, we might not have to be removing ovaries. In the last decade or so, we've discovered that ovarian cancer actually doesn't start in the ovaries. It originates in the fallopian tubes. Currently, there's a study being done internationally looking at removing fallopian tubes first and then waiting 5 years before removing the ovaries. So for example, a BRCA1 carrier at 35 would have her fallopian tubes out, and then at 40 would have her ovaries out. So still meeting the current guidelines, but then we would be able to see whether anybody develops ovarian cancer between the ages of 35 and 40. So we are expecting to have that data, I'd say, in the next 5 years. So moving on to pancreatic cancer, again, it's not that common, 5 to 10%, maybe a little bit more common if you also have pancreatic cancer in your family. It's important if you're a mutation carrier, and for anybody actually in general, that you don't smoke. Smoking does double people's risk of pancreatic cancer. For screening, if you don't have a family history, we recommend screening with diabetes every 3 years from age 40. And if you newly develop diabetes, then we do imaging of the pancreas. If you have a family history in a close relative, like a parent, brother, sister, aunt, uncle, that kind of level, who had pancreatic cancer, then we do a more intensive screening program involving having an MRI of your pancreas 1 year, and the following year having a procedure called an endoscopic ultrasound, which is when a gastroenterologist puts a scope into your stomach that has an ultrasound probe on the end of it, and they can look through your stomach wall at the pancreas to see if there's a lump in it. And we start that screening from age 50. That screening has been shown to allow detection of pancreatic cancer when it's earlier than if you don't do screening. And with pancreatic cancer, unless you find it early, it's basically not curable. Prostate cancer in BRCA carriers is different than prostate cancer in the general population. I think most people get the message from the media that prostate cancer is not a bad cancer, which is true for the general population. If you get prostate cancer, you probably won't die from prostate cancer, which is probably true for the general population. But for BRCA carriers, the prostate cancer tends to occur at a younger age. It tends to be more aggressive, and it's also associated with poorer outcomes. So our recommendation is that from the age of 40 in BRCA2 carriers, and considering it in BRCA1 carriers, though the risk is not as high, that men have a rectal examination, a digital rectal examination, to see if a mass is felt, a lump, by their doctor. And they also have a blood test called a prostate-specific antigen. And then if either of those tests are abnormal, they would have further investigation. including potential biopsies. So as I mentioned earlier, I wanted to include a little bit more information about lifestyle issues and cancer risk. At the high risk clinic, we do kind of have this general, I guess I'll call it a motherhood statement, about healthy lifestyle, and saying that it's associated with decreased cancer risks in the general population. And of course, this is not known, proven in mutation carriers, but I thought it would be helpful for people to really get a sense of how much impact on cancer risk and cancer outcomes lifestyle issues do. So, excuse me. Smoking is associated with a 10% higher risk of breast cancer if you smoke more than 10 years. So that's compared to the general population. And it's also associated with worse outcomes if you get breast cancer. Smoking doubles the risk of getting pancreatic cancer. And if you have prostate cancer and you're a smoker, you have a 40% higher chance of dying from your disease than if you're a non-smoker. Alcohol also increases cancer risk. Having 3 drinks per week is associated with a 15% higher breast cancer risk. We believe that has to do with the effects on estrogen levels in your body. There's actually a direct, like 1-to-1 correlation. So with each drink per week that you have, more your breast cancer risk goes up. Being overweight is associated with increased cancer risks. So there's a 12% increased breast cancer risk for every 5-point increase in a body mass index in postmenopausal women. So it is not good to gain weight postmenopausally. Women who are overweight also have an increased risk of breast cancer recurrence. Both of those are probably due to the fact that women who are overweight have higher circulating estrogen levels because of the way that estrogen is made in our bodies postmenopausally. Obesity is also associated with a 20% increase in pancreatic cancer risk. And there's a 10% increased risk of death from prostate cancer if you do get prostate cancer for every 5-point increase in body mass index. Regular exercise, so that's the usual like 150 minutes per week that you read about in most magazines or online now. People who exercise regularly have a 10 to 20% lower breast cancer risk. And they also have a 30% lower risk of death if they develop ovarian cancer. Vitamin D deficiency is associated with some increases in cancer risk. Having enough vitamin D in your body compared to not having enough vitamin D reduces your risk of breast cancer by 45%. It might lower the risk of ovarian cancer having enough. And if you have enough vitamin D, there's about a 13% lower chance of dying from ovarian cancer. And there's also a lower chance of dying from prostate cancer if you have enough vitamin D. So vitamin D deficiency is very common in British Columbia because of our lovely 10 months of rain. So we do encourage patients to take 1,000 international units of vitamin D daily. Again, we don't know that these are the same numbers for mutation carriers, but we don't have any reason to believe that they wouldn't be the same for mutation carriers. And I think that's my last slide, and we're open for questions.